Okay, so we're going to keep on going. This is our lecture, chapter 10, part 2. We're going to keep on rolling through the kidneys here. And we're going to start with congenital anomalies. So last week we kind of talked about um, what a kidney, like the anatomy of the kidney. And this week we're going to talk about like some things that can go wrong with the kidney and what they look like on ultrasound. So you can have agenesis or hyperplasia of the kidney. And we kind of talked about this a little bit last time, where is where there just is not a kidney, which some people don't find out that they don't have a kidney until they are in adulthood and they're just getting a scan and we can't find a kidney. Um, and so they only have one kidney just by design. Hypoplasia is more what happens later on with like renal failure, where there's just diminished function in the kidney, and one kidney is not working in strengths, the other kidney is going to get larger. So in unilateral renal agenesis or hyperplasia, it's not considered life threatening because you only need one kidney to survive and function. Though sometimes kidney and renal function will go down. Bilateral renal agenesis is not compatible with life because you cannot function without kidneys. And so sometimes in a fetus, you will get a baby that does not have kidneys, and we scan those babies, but there's really, if you don't have kidneys, there's no way that you can survive. What it appears like on ultrasound is the baby is not going to have any fluid around it, and we're not going to see the urinary bladder. Complete duplication of the ureter is the most common congenital anomaly, and this happens more frequently in women than men. It's associated with early development of renal diseases. Sonographically, you're going to see identifying separation in the normal renal sinus. Echo densities contributes to the diagnosis. If dilatation is present, the sonographic characteristics simulate hydronephrosis or a large cyst. So you're going to have two ureters going into the kidney, which is really pretty interesting. So we utilize sonography to determine the presence of the kidneys, exclude hydronephrosis, exclude a duplication anomaly, identify a ureterosil in the bladder, or guide percutaneous puncture if indicated. You can also observe the ureteral jets in the urinary bladder to look for duplicated ureters. So I love the images because it's just going to be your best bet of being able to, see what we're talking about when I'm talking about a duplicated system. So in image A, you can see that they're in the echogenic renal sinus. There's a duplication from the fact that there is tissue that has separated the two renal pelvises. So you'll have two distinct renal sinuses. And so that's one way that you can tell that there is probably a duplicated system, is just from that. Now in B, it's a different patient. And this is just really like a beautiful picture, I think, of you can see both of the ureters are dilated because there's probably a obstruction down near the bladder, but you can see both of the ureters going into the kidney. So this is suggesting, of course, a duplicated system. Now, interesting enough, like you could look at this and be like, well, how do I know it's just like not a dilated renal vein? Or like, how do I know? I'm like, you always want to put color on these, because if there's no color and no color Doppler, then you can think that it's probably a ureter. Image C is going to be what we were talking about with the ureteral jets. So another thing that you can do is look at the ureteral jets, and you'll see if there are two ureters, you're going to have two ureteral jets on the left side and one on the right side here. A supernumerary kidney, yeah, this seems to always happen in organs. We talked about it with the spleen a couple of weeks ago. But complete duplication of the kidney, pelvis, and ureter is a rare condition believed to be due to splitting of the nephrogenic blastema before or at the time of the union of the ureter bud. So duplication occurs with equal frequency on the right or left side and can be bilateral. So if you have an extra kidney, like it has its own blood supply, but the extra kidney is usually ectopic and the ureter usually joins the upper kidney ureter. So there is a common ureteral opening into bladder trigone. I personally, this is pretty rare. I don't think I've ever seen this before, like three kidneys, but I do, know that it could potentially happen. But yeah, I've never really seen it. Maybe it's because an extra kidney, which is not suspected and is ectopic, may be overlooked during a routine exam. Because why would you start, if you see both kidneys, why are you going to start looking around in the pelvis for another kidney? So it could be something that is just an incidental finding on like a CT where they are scanning the entire body, but it's pretty interesting. So when we talk about ectopic kidneys, we're talking about kidneys that are not in the flank space where they should be in the right and left side. So there's different categories. There's a pelvic kidney, those I've seen the most likely, intrathoracic or cross-fused kidney. So pelvic kidneys occurs when you metanephros, which is you have three types of kidneys when you're like a small embryo, and then the metanephros is your last set of kidneys, permanent kidneys. And they develop in an abnormally low position, which results in abnormal ascension of the kidney. Pelvic kidneys are normal or slightly smaller than normal and lie just above the pelvic brim or sometimes even within the pelvis. Now, I've seen these in adults, but what else is really interesting is I've seen them in fetuses. When I am scanning a baby, we're always look for both kidneys. That's one of the things that is on your list of your protocol when you're doing an anatomy screen. And so if I only see one kidney, I tend to think potentially there might be a pelvic kidney. And so I'll look in the pelvis to see if I can see an extra kidney that has just not risen to its spot. And there has been times when I have found a kidney in the pelvis of a fetus. So you're scanning, your patient, and you look where you should be looking by the liver for your right kidney. And then the image of the left upper quadrant, then you go to the left side and you don't see a kidney over there. But then you're like, okay, this person's alive. They have to have a kidney somewhere. You can't function without kidneys. You have to have at least one. So then you start looking in the pelvis, and lo and behold, there's a kidney, a single pelvic kidney in the left lower quadrant. A rare development anomaly results when the kidney continues to ascend and goes into the thorax, thought to be associated with delayed closure of the thoracic cavity. With intrathoracic ectopic kidneys, diaphragm closes below or around the kidney. If kidney infection or obstruction develops, thoracic symptoms may occur. Now, I have never seen this either. This is very rare, but if someone would do a report on that, that would be awesome. You can also have cross-fused kidneys where both kidneys are located on one side of the body. The condition is relatively uncommon. Infusion to the contralateral kidney is more common than the unfused type. So the upper pole of the crossed ectopic kidney is usually fused to the lower pole of the normally rotated ipsilateral kidney. So they're going to look fused, going to look like one giant kidney. So here is an interesting picture of this. Um, E, picture E, you can see a small right kidney that is fused to the left kidney inferior pole. Isn't that crazy? So in the three types of ectopia or ectopy, there is an associated rotational anomaly in which the kidney pelvis facing anteriorly is common. So the vascular insertion into the aorta and IVC may be displaced. Longer renal vessels have more a tortuous path, making kidney obstruction and infection more likely. Ipsilateral crossed ectopia or pelvic kidneys are associated with a higher incidence of bacterial infection, calculi because the ureter is kinked, they're tortuous. And the pelvic kidney can be confused with a palpable pelvic mass. CT, IVPs, or radionuclide renal scanning can aid in confirming the diagnosis of this. An IVP is something that is done like in radiology where they put dye and then they watch the kidneys, renal pelvis go through, like the blood, or it goes into your blood, filters out, and goes out through the bladder. So that would be a good way to double check this. Horseshoe kidneys. They're the fusion of the upper and lower kidney poles during a fetal development produces a horseshoe-shaped structure. Now, I've seen quite a few of these. This is a common anomaly, actually, 1 in 400. So this is going to be something that you see, and you're going to be like, oh, yes, I know what that is. Majority are fused with an isthmus composed of a simple cord or fibrous band at the lower pole. With lower pole fusion, the ureters usually pass anterior to the renal parenchyma and most often is asymptomatic and capable of normal function, but could be associated with hydronephrosis, infection, or calculus. Patients often are referred for evaluation of a pulsatile mass, and then when we scan, there's a kidney there. When the mass is identified on sonogram anterior to the abdominal aorta, a horseshoe kidney should be considered. So A is the long image of the right, demonstrates a lack of definition of the inferior pole. We can't really see the inferior pole. We're like, what the heck? It kind of just drops down. So B, the image of the left, also demonstrates an indiscernible left pole, inferior pole. So long image made over the mid-abdomen demonstrates the isthmus anterior the aorta, representing the inferior pole of the fusion of these two kidneys. Now, most of the horseshoe kidneys that I have seen, um, are going to be lower in the pelvis. So now we're going to go to cystic renal masses. We're going to talk about cysts a little bit. There's a lot of cysts. Okay, so cystic masses of the kidney may be hereditary alterations like polycystic kidney disease, hereditary but developmental or acquired disorder. So there's multiple different cysts, and it's important to know what they are because then you can kind of just in your head know, although you won't be diagnosing. Sometimes this can be confused for malignant tumors, but sonography is a great way to determine the if it's a cyst because we have our simple cyst criteria, right? Versus solid lesions. So in chapter 20, it talks about newborns and children's cystic dysplastic kidney, multicystic kidneys, or infantile polycystic kidney. And I will talk to you more about this in your chat OB23 next semester. So we go over the three different types of kidney diseases in a fetus. So autosomal dominant polycystic kidney disease is relatively common. It accounts for 8 to 10% of patients who require chronic dialysis. And the reason why is that these cysts decrease the renal function and tends to cause kidney failure around the same ages in members of affected families. So it's a genetic disorder. So if someone has it, you have a pretty high chance of potentially getting it. If calcifications are present with this, they're associated with the cyst, they can appear thin, ring-like, curvilinear, or small flecks. Patients can have cysts in the liver with this, pancreas, lungs, spleen, ovaries, just everywhere. Cerebral artery aneurysms in the circle of Willis also occur with this, but in 16% of patients. My favorite is medullary sponge disease. I don't know why I like this disease. I think it just is really interesting. So it's relatively common, usually innocuous structural change restricted to lesions and multicystic dilatation of collecting ducts and medulla. So what that means in terms that are easier to understand is basically there's a lot of dilatation in the collecting ducts, and they're so small they appear more achogenic. Conditions occur in adults, usually bilateral, and normally discovered as an incidental finding. Renal function is usually normal with this. And I think we're going to go back later and I'll show you images of each one of these, but we're just kind of going through the list right now. Nephrolithiasis is a rare progressive familial hereditary disorder, usually has its onset in young adults or children, characterized by the presence of variable numbers of cysts in the medulla. It's terminal renal failure, though, over 5 to 10 years. So that's a pretty sad one. Okay, so here's our congenital cystic renal diseases. I want you to know each one of these, what causes, the clinical features, and what they look like on sono. Here is an image of a polycystic kidney. Look at all of those different little cysts all around. So when there's so many cysts like this, they're going to interfere with renal function. And that's why patients have to go on dialysis. Their kidney, as the more cysts develop, the kidney function goes down. You can have little cysts and you can have big cysts. This is a picture of a man with multiple views of the right and left kidney having this. So he probably by this time is on dialysis. All right, my favorite, medullary sponge disease. Look at the renal pyramids. They're all hyperechoic. The cortex looks thin. I've seen this, I would say, quite a few times. Of all of these three diseases, probably the most medullary sponge disease. This could be an incidental finding because their renal function is normal. All right, we're going to skip those because we got lots to do. So simple cyst. Most often, and there is a discussion question about this, so good job on that. Most often seen renal cyst is a simple serous fluid collection originating in the renal cortex. One cyst is not going to hurt the kidney. It's this polycystic stuff. Simple cysts are being identified with increasingly frequency in younger adults and in pediatric patients. The prevalence of cysts increases markedly after 40 and is identified approximately 50% of patients after 50. So they're very common to just have one single cyst. Avoid confusing simple cysts with polycystic kidney disease. There's usually not going, when they don't have some kind of polycystic disease, there's not going to be more than probably 4 cysts each time on each kidney. So that's kind of one way that you can kind of differentiate that. They can get large though. They have epithelial lining and vary in size from 1 millimeter to giant cysts containing 5,000 milliliters of clear amber fluid. They're usually unilocular but may have a septation and can be located anywhere on the kidney, including the adjacent tissues of the renal pelvis. So if a kidney is very large and it's in the renal pelvis, there could be potentially some obstruction starting to go on, and then those that would need to be removed. But if it's on like the inferior pole of the cortex and not really bothering anybody, it's about 3 centimeters, they're going to probably just keep it be and we'll do follow-up ultrasound on it. For a sonographic differential diagnosis, these lesions must meet the classic criteria for a cyst. So here's our simple cyst rules. Remember, clear, smooth wall. So we're going to have a smooth wall. We're not going to have any kind of projections into the cyst. They're going to be spheric or slightly ovoid shape. No internal echoes within it, and posterior enhancement. Sonography cannot determine if a cyst is benign or malignant, but most are benign, especially if they're cyst or simple like that. 5 to 10% of complex renal cysts, though, are proven to be tumors. So here's our stuff about cysts. Here's a couple cysts. A shows common location of simple atypical renal cysts, and this is what I usually see. So they're going to be like on the inferior pole. There's cortical location, not bothering anybody. So you would measure in 3 planes with these cysts. You do a long and transverse view, and then you would put cyst, say cyst seen. Here's a little bit larger of a cyst. but still, I don't believe that they would do anything with this. Complex cysts. So you can have hemorrhagic cysts. So 6% of simple renal cysts show hemorrhage, and the prevalence of hemorrhage increases in polycystic kidney disease. Depending on age of the bleed, clot, and resorption, hemorrhagic cysts vary from anechoic to complex masses, with or without acoustic enhancement. Lesions not meeting classical criteria for a cyst should be investigated by aspiration or CT, and the presence of blood on CT in any form increases attenuation. Hemorrhagic cysts appear hyperdense. So you're going to have like the same cystic criteria, but then you're going to have internal echoes. So in image A and B, this is the left kidney demonstrates a complex cystic mass with low internal echoes, but there's not going to be vascular flow, which is a huge thing. If there was some vascular flow, you could think that potentially this could be a malignant mass. But when they did a aspiration on this, it was an abscess, but could also have the appearance of hemorrhagic cyst. So simple cysts can become infected by bacteria, just like a lot of stuff. Like if a patient has a bladder infection, or a kidney infection. The infection is rare and accounts for 2.5% of complication. Patients present with fever and unilateral flank pain. Infected cyst is resistant to antibiotic therapy. Cysts usually contain cloudy fluid versus purulent contents of abscesses. Debris often shifts when patients change positions. Sonography is useful for guided aspiration and drainage. So cysts can also be septated or multilocular, but usually they're going to have like one single smooth cavity. But some cysts are trabeculated or divided by fibrous septa into two or more compartments. Septations usually don't have any pathological significance unless there's papillary projections, which are little echogenic things on the wall that are protruding into the cyst. That kind of gives me, and this is kind of the same thing as our cyst that we talked about in our ovary, our OBGYN one class, papillary projections, a septation that has vascular flow. Those are more common signs of possibly a malignancy than just a septated cyst that does not have those things. So here's a couple. Okay, so in D, there's a large cystic mass with some septations there and mural calcifications. This is another really interesting cyst with all these little small septations. I've seen this a couple times, but this kind of cyst would probably want to be investigated out a little bit more because it just looks so funny. So these are our little box for the renal cystic masses. You could have calcifications in cysts or a calcified wall. They say that many were hemorrhagic or infected at one time. Let's look and see what it looks like. Here's a cyst, and it's like just more of an echogenic wall calcification, so it probably wasn't infected or hemorrhagic cyst. And this is the cyst seen on x-ray. Here's another image. I've seen this quite a few times actually, like kind of look like this. It's a renal cyst with a calcified rim. Milk of calcium is most common in renal cyst. MOC primarily represents a small calcium carbonate crystals, but can form from other substances. MOC is deposited in most cases in the calyceal diverticula. MOC is usually asymptomatic and requires no treatment. These are little cortical cysts called milk of calcium cysts. So you can have a calcified cyst or an MOC in renal cyst. They say the cause is from inflammation on the MOC renal cyst. So within the calyx, an anechoic area containing hyperechoic foci with acoustic shadowing, the foci may shadow movement with changing positions. So here's the cyst, and then the little echogenic vein is below. You can also have parapelvic or peripelvic cysts. They originate in the renal parenchyma and protrude from the renal sinus. Neither of these two cysts communicate with collecting system. Parapelvic cysts are generally solitary and large, and peripelvic cysts are small, multiple. Again, you're not going to be saying what kind of cyst this is. You're just going to put simple cyst or hemorrhagic cyst, but it's good for you to know a little bit about it. So, but we'll just look at our little box here, and this is everything you need to know really right now. So anechoic, peripelvic cysts are solitary, peripelvic cysts are smaller or asymptomatic, but they may be associated with hypertension hydronephrosis because they could get in the way because they're in the pelvis, renal pelvis. So they could get in the way of the artery and the ureter. Here's a peripelvic cyst. And like how I would say this, I would say simple cyst seen in the renal pelvis and then measure the cyst and put the measurements in. And that's where I would leave it at. But it is good to know that there are different kinds of cysts. Now, there are cysts associated with systemic disease. So, tuberous sclerosis is one of the diseases that sometimes we can, you want to get diagnosed, and they have growths on their skin. They can have rhabdomyomas in their heart. There's multiple different things that can occur with tuberous sclerosis. Kidneys are affected in approximately 95% of adult patients, and so they're going to have cysts. So I think I'm going to show you this, and then we'll be kind of done with the cysts. So this is a patient with tuberous sclerosis. You're going to see multiple angiomyolipoma. So like if you looked up tuberous sclerosis, you would see that they just can grow different kinds of masses throughout their whole body. And it is one of those things that if I do see a large mass within or a mass in the heart during fetal, it's one of the things that they check for. So it's basically it causes the growth of like benign tumors like in the kidneys, heart, eyes, lung, and skin. So this is what kind of grows in the kidney. It's not a very great disease. Von Hippel-Lindau is another cysts that are associated with a disease. Kidneys are involved in about 59 to 63% of patients. Renal cysts may be the first manifestation of the disease. Okay, I'm ready to be done with cysts. We looked at all the cysts um, that we could. There's a lot of cysts, right? Um, so now we're going to move to renal masses. So benign neoplasms, malignant, metastatic renal tumor. So I was like, thank you. I feel like this is what we need to be, after a while, like a lot of cysts are, it's just confusing. There's so many different kinds of cysts. It's ready to move. Okay. So the sonographer's role providing examination to differentiate conditions, which include simple or atypical cysts, pseudotumors, renal infarction, angiomyolipomas or hamartomas, lymphoma, metastatic neoplasm, benign mesenchymal tumors, RCC adenoma or oncocytoma. Oncocytoma. I get nervous about little renal cell carcinomas because they are indistinct. And if you're not paying attention very close, you could miss kidney cancer really easily. So you always have to be on your guard. Like you will do so many kidney ultrasounds that it can feel like you just are flying through them, but you have to every single time look at the cortex. Be very intentional about your scan because renal cell carcinoma likes to just blend in, especially in its first couple stages. So that's going to be my um, advice to you is to just make sure that you are every single time looking for irregularities in the cortex. So a sonographer's role in patient assessment plus this is identify the exact location of any mass, distinguish between cystic complex and solid tissue. And we know how to do this, right? We know what a cystic mass looks like. We know what a complex mass looks like. And we know what a solid tissue looks like. So you'll manipulate your gain, your TGC, your focal ranges to provide an accurate representation of tissue. You'll document the number of masses and evaluate contralateral kidneys. You'll make volume measurements. You'll document the growth rate of the mass or any follow-up exam. So what that means is like, every 6 months, the patient might be getting scanned. You want to make sure that you look at the previous and then you compare it to this one and you assess for vascularity of solid masses. So renal cell carcinomas are hypervascular and contain numerous AV shunts. So you always want to put any kind of blood flow on the mass. So adenoma is the most prevalent benign kidney tumor found often as an incidental finding at surgery or autopsy. They're usually measuring about 1 centimeter. They're rarely larger than 3 centimeters, and they are asymptomatic. So these are the vascular benign masses are believed to be the counterpart of the malignant or renal cell carcinoma. One theory is adenomas smaller than 3 centimeters rarely metastasize. So adenomas and adenocarcinomas usually occur in the 6th or 7th decade of life. I want you to know that, and have the same male to female ratio. Adenomas may be responsible for pain hematuria, blood in the urine. In the sonography, appearance of renal adenoma has a pattern of a similar to RCC. So they would have to biopsy this to tell whether this is malignant or benign, because it seems like these adenomas have the same kind of appearance as RCC. Oncocytomas is a class of very large vascular adenomas, usually occur in middle to old age. Male to female ratio is 1.7 to 1, so a little bit more of in a male. Usually cannot distinguish on sonogram from typical RCC, which may explain why oncocytomas account for 2% to 14% of renal tumors thought to be cancer. An angiomyolipoma. These are what grow in the a patient with tuberous sclerosis. Benign hemangioma, mesenchymal mixed tumors composed of fat cells intermixed with smooth muscle cells and aggregates of thick wall blood vessels. They can occur as a solitary mass or multiple bilateral masses, which that's what happens when the patient has tuberous sclerosis. Focal hemorrhage with evidence of necrosis, cystic degeneration, or calcification within the lesion is common. Malignant transformation is thought to be extremely rare if it ever occurs. So that's good. Strong echogenicity, even at low gain settings, is due to the high fat content. And you remember the little masses I showed you in that one patient with tuberous sclerosis, that's kind of what they look like. So here is one right here that where the arrow is pointing. And it's echogenic because of the fatty material. B and C and D are all different angiomyolipoma. See how echogenic they are. I like our little boxes. So this is kind of what I want you to know. Lipomas are going to be with fatty tissue too. Leiomyomas also are like fibroid tumors, but also can in the uterus, but also can form in the retroperitoneal. A hemangioma is rare, no sex preference, occurs third to fourth. Patients might have hematuria. They're usually less than 1 centimeter. Fibromas are hypercooked masses in the medulla, rarely in the cortex, 2 to 3 millimeters. Multilocular cystic nephroma are large anechoic space up to 10 centimeters. Has the appearance of a Wilms tumor, which we'll talk about. The ones I really want you to know are probably these three. Adeno, angio, what a lipoma looks like, a hemangioma. Those are the ones. Okay, so we're going to talk a little bit about a renal cell carcinoma, aka hypernephroma or adenocarcinoma. It represents 1 to 3% of all visceral cancers. You know, an adenocarcinoma was also a cancer that most common cancer in pancreas, if you guys remember that. It's the most common malignant tumor of the kidney, about 80 to 90%. Occurs more often in after age of 50 and has a 2-to-1 male to female ratio. So if a patient already has something going on with the kidney, they have a higher chance of getting a renal cell carcinoma. So the ADPKD stands for adult dominant polycystic kidney disease. And tuberous sclerosis has a higher, and von Hippel, which also causes tumors and cysts, has a higher chance of having renal cell carcinoma. So anything that has a higher chance of growing something on the kidney has a higher chance of it being malignant. Hematuria is, so the classic symptoms are costovertebral pain. So you're going to angle pain. So you're going to have pain in your flank and on the sides, a palpable mass, and hematuria. But only about 15% of these patients present with all three symptoms, and hematuria is the most significant. Histologically, RCCs are described by cell type, clear cell or granular cytoplasm, or cellular morphology. Tumor size varies greatly and may infiltrate throughout the kidney. Tumors often appear to have a capsule or pseudocapsule. RCC spread to the paranephric fat and the renal vein. 30% of patients have metastasis by the time of diagnosis because it is just a tricky little thing. And 75% of these belong to the lungs. So there it's going to metastasize to the lungs pretty fast. Bone, opposite kidney, liver, adrenal, brain. So stage one, if the tumor is just within the kidney, small or large, and it hasn't metastasized, there's about an 80 to 100% survival rate. A tumor in the paranephric fat is 65 to 70. If the tumor is in the renal vein, lymph nodes, or vena cava, it goes down to about half. If it's adjacent organ invasion, distant metastasis, tumor in dextroregionals, it has stage 4 and it has 0 to 20%. So it is not significant, or it's not like a good survival rate. And that's where a lot of the times people find them at, is by that time. So I think that's kind of just like a lot of the like ovarian cancer called the silent killer, because honestly, by state, it's diagnosed by like stage 3, stage 4, and it's already metastasized to other parts of the body by that time. So here's a image of stage 1, stage 2, stage 3, and stage 4. RCCs are highly vascular and contain numerous areas of hemorrhage, necrosis, and cystic degeneration. 10% are hypovascular, and many represent a microscopic subclassification known as papillary adenocarcinoma. So if you have papillary adenocarcinoma, you have a higher chance of having a better prognosis because they don't grow as fast. So the sonographic appearance is compared to the normal adjacent. So 50% of them appear a little bit hyperechoic. 40% appear echogenic, and 12% are markedly hyperchoic. And I wish they were all that because it'd be easier to see. Isochoic masses are detected when they are exophytic or distort the renal contour, which the ones I have seen are just distort the renal contour just a little bit and are isochoic and look almost exactly like the renal cortex and are terrifying because I was like, oh my gosh, I'm so thankful that I was able to see that. This one would be pretty easy to see. So this is a renal cell carcinoma in the right superior pole of the right kidney. And I like to point out power Doppler on D, how vascular this mass is. If they were all that big, it'd be easy to see, but they aren't all that big. And if you look at C, it looks like almost it's a hypochoic mass, but it almost is the same echogenicity of the left kidney cortex. So if it was very small, about 1 to 2 centimeters as it starts out, it would be difficult to really visualize. So there's no correlation between tumor vascularity and tumor echogenicity. The degree of hemorrhage and necrosis does determine the degree of echogenicity. RCC, that mass that does not attenuate sound, is one that has undergone complete cystic or hemorrhagic transformation. Ugh, here's another nasty mass. So um, you can see on the um, CT, sorry, you can see the mass there. And then here is what it looks like on ultrasound as a nasty cystic solid mass. Here's another one that is within the medulla of the kidney. So extension of a renal cell carcinoma into the renal vein occurs about 20% to 30% of patients, and renal thrombus may extend into the IVC in 5 to 10%. So patients have a higher chance of having like a renal thrombus with RCCs. So with duplex ultrasounds, vascular ultrasound, like the IVC and the renal vein are going to have like that phasic flow of breathing. In the presence of thrombus or obstruction, the Doppler signal may be damped, absent, or continuous. So here is an image of that. This is the mass in image A. This in B, there is reveals a soft tissue mass within the lumen. In C, there is a renal mass and then the tumor invasion. A Wilms tumor is nephroblastoma, and Wilms tumor is a highly malignant childhood tumor. And chapter 20 will include that, or we will talk about it some in our kidney chapter in OBGYN too. So, but a little bit about it is that it's the most common type of kidney cancer in children's. the children. It's known as a nephroblastoma, and it affects kids around 3 to 4. Good thing about the Wilms tumor is it has a very good outlook, so prognosis wise. So, although it's very malignant, it does not have, it has a good prognosis. Urothelial carcinoma is malignant tumors of lining of the renal pelvis, calyces, ureter, and bladder, and it counts about 8 to 10% of renal cancers. The majority are transitional cell carcinomas. The remaining 10% are squamous cell carcinomas and are rarely adenocarcinomas. Tumors are small and usually not palpable, but may block the urinary outflow, cause hydronephrosis. Good thing about surgical removal with these carcinomas is that it has a good survival rate of 90%. So transitional cell carcinomas represent about 7% of renal neoplasms, 90% of primary renal pelvis tumors, and more than 90% of cancers of the ureter. And patients usually present with painless hematuria. They're more common in men than women, and tumor is usually multiple or bilateral. Transitional cell carcinomas are also cancers that are in the bladder too. So that might be a way for you to remember that. So there's 2 sonographic patterns: the splitting or separation of the central echo complex, similar to the hydronephrosis, and a bulky hypoechoic mass lesion. So basically, if you have a tumor that's located in the renal sinus, it has a very high chance of having a transitional cell carcinoma. So if you had to see, you had a patient with a renal cortex mass, or you had a patient with a renal pelvis mass, which one do you feel like would probably have a better prognosis? And if you said renal pelvis mass, you're correct, because it's probably more of a transitional cell carcinoma instead of an adenocarcinoma. Let's look here. So here is the mass and a transitional cell carcinoma and A. So it's just, okay, you have your really echogenic, pretty medulla, but then M is like more hypoechoic. And this is in a 79-year-old woman's right kidney, reveal a hypoechoic mass located in the renal sinus. Squamous cell carcinomas are remaining 15% of urothelial tumors and are highly malignant. They metastasize early with poor prognosis and associated with renal calculi and infection. So diagnosis is suggested by the presence of faceted calculi marked with hydronephrosis from the uretero-pelvic junction obstruction. Metastatic renal tumors, the kidney has profuse blood flow and is frequently the site of metastasis of carcinomas and sarcomas arising from other organs. So not only does the kidney have its own thing going on, then the lung and breast tumors are the main source of the kidney metastasis. So RCC of the kidney is the only malignancy that selectively metastasizes to the opposite kidney. Lymphoma, secondary involvement of the kidney by lymphoma, including Hodgkin's lymphoma and leukemia, occur with significant frequency. Manifested by nonspecific kidney enlargement. In Hodgkin's disease, the incidence is about 10%. Malignant lymphoma incidence varies from 35 to 60%. Sonography, most lymphomas present as anechoic or hypoechoic single multiple masses. Characteristically, the lymphosarcoma is bilateral. Pattern of the tumor growth is into the paranephric space, so it surrounds and encapsulates the kidney. It may appear anechoic because it has few internal reflectors and simulates renal cysts. Okay, we're going to keep going with hydronephrosis. I feel like you could spend like 8 weeks on the kidneys, to be honest. So hydronephrosis represents urine dilatation of the renal pelvis, calyce structures, and the infundibula, often found incidentally in an asymptomatic patient during routine obstetric sonography. So occurs in about 65 to 85% of pregnancies. The incidence is greater in the right kidney than the left. The cause of hydronephrosis and the reason for right-sided preponderance remains controversial, but a patient, if they do have like flank pain in pregnancy, will scan. And I can tell you from a lot of experience that the right kidney is most likely to be the one affected with mild to moderate hydronephrosis. So the grades. So grade 1 is mild, minimal separation of the sinus echoes, about 2 millimeters. Grade 2 is moderate, anechoic separation of entire central sinus with continuous broad anechoic band distension into the intrarenal pelvis. And grade 3 is marked, extensive separation of central sinus and calyces with parenchymal thinning and a single blown out ellipsoid anechoic collection spreading central echo complex with loss of individual calyces structures. So there can be intrinsic reasons why you get hydronephrosis that include like a hematoma, a neoplasm, a stricture, obstruction, pyelonephrosis, or you can have extrinsic, gosh, which is a neoplasm, trauma, neurogenic bladder surgery. So stuff that can occur in the kidney that causes hydronephrosis or outside the kidney that causes hydronephrosis. The hallmark of sonography when looking at hydronephrosis is you're going to see splaying, spreading, or ballooning of the central echo complex. Extent can be graded based on sonographic appearance. This sonographer should document an extent and must attempt to document its cause. So examination includes imaging the ureters for dilatation, prostate for hyperplasia, urinary bladder for calculi, tumors, or ureterocele, pelvic structures and retroperitoneum for pregnancy tumors, and urethra for posterior valve stricture, which is rare. Here's an image of hydronephrosis. There's multiple different. So moderate is what I usually see in pregnancy, where you can see the ballooning there. And then the calyces, intrarenal pelvis and calyces. With severe, it's going to look more like this, like a big ball. So this is like grade 1 hydronephrosis in a 61-year-old woman presented with bilateral flank pain. Long images of the right kidney, left kidney demonstrates mild distortion. Different with grade 1 with mild separation of the renal pelvis. Here's grade 2 hydronephrosis. You can see the calyces and renal pelvis on two different patients. We'll see the difference there. This is pretty severe hydronephrosis. And the arrows there are pointing to urolithiasis, which is potentially causing it. Doppler examination can be used to evaluate hydronephrosis because the obstruction produces hemodynamic changes with intrarenal vasoconstriction and elevation in renal artery resistance, which may be detectable before pielocalcinosis can be observed with sonography alone. So one thing is you don't want too heavy of or too full of a bladder because that can actually cause pseudo hydronephrosis too. So conditions that simulate mild hydronephrosis are normal variance, increased urine flow over when patients have overhydration, inflammatory disease like acute pyelonephritis or chronic pyelonephritis, renal cystic disease, or like post-obstructive or post-surgical dilatation. It's important to remember that hydronephrosis causes spreading of the Kalos echoes, and some entities that simulate hydronephrosis, cystic disease, compress the central sinus echoes. So you need to evaluate the remaining kidney cortex as it indicates how much function the tissue remains. If you can identify the dilated ureter and continuity with the cystic mass of the upper pool, it's helpful in making a diagnosis. Diagnosis most likely is the ureter pelvic junction obstruction. Okay, we're going to do lithiasis and be done for today. So we're almost there. There's multiple different theories explaining stone formation. And I'll let you just kind of look through that on your own time. There's multiple different types of stones too. Calculate can develop anywhere in the urinary system, but it's most developed in the kidney, which is called nephrolithiasis. And it's pretty, I don't know. I would say it's pretty common. I mean, you hear people have kidney stones. Um, could be up to 5% of population in industrial countries. More common in white men aged 20 to 50. And I heard they hurt so bad. Um, it kind of depends on where they are. But if they're like passing, I heard the pain is just terrible. Nephrolithiasis situated within highly reflective central echoes of renal sinus collecting system are difficult to discern unless calculi are large and cast an acoustic shadow. 80% of stones contain some sort of calcium, and you're going to see an echogenic spot within the kidney that shadows basically. It's going to have a dense echo pattern, sound attenuation, and a strong acoustic shadow. So you're always looking for these when you're doing kidney ultrasounds too, especially with flank pain. Ureteral stones are more difficult to visualize with sonography and may only be detected if the ureter is significantly dilated. On sono images, most calculi appear as echogenic structures. So here's an image of a kidney stone in a 24-year-old girl causing with left lower quadrant pain. You can see that echogenic ball, like that's within the center with the arrow and then a shadow going straight down. That is a picture of a stone. There's a couple other. I love the shadowing sonographic sign that really helps you out because sometimes with kidneys, they can look a little like there can be little echogenic areas just in the medulla that's just part of the kidney and it can trip you up. But most of the time, they're not going to have a very distinct shadow like the stone is. And so that really will help you figure it out. And D, it's a color Doppler image of the same patient demonstrates the twinkle artifacts posterior to the stone. So you can also put color flow on and you can see how it kind of like twinkles in a different color right through there posterior to the stone, and that might help too identify them. Here's a couple other stones you can see in the arrow on E, and you can see again that shadowing. So this is an interesting one. A 40-year-old man presented with hematuria, sonography evaluation of the left kidney reveals a staghorn calculus, which is a huge calculus that is filling the whole renal sinus. Long section of the left kidney demonstrates a strong acoustic shadow emanating from the renal sinus. Look how big that is. That probably hurts. Here's another image. Let's see. And you can see that what it looks like on CT. Okay, I think we're done for the day. Thanks for hanging in there with me. I know this is so much information and you're doing great. And we'll talk more about urolithiasis and continue on. Oh, let me just finish this off real quick. I'm sorry. Psych. So, in 80% of renal stones or 88% of ureteral stones, and they display some kind of twinkle artifact. And this suggests it could be considered another sonographic criteria. So a twinkle artifact is a rapidly changing mixtures of color visualized posterior to the rough, highly reflective structure on the color Doppler. So you're going to see it changing all these different colors. It's called like it twinkles. So that might be another way that you can decide to see or like help you diagnose a stone. There's a picture of it. To consistently obtain a twinkle artifact, a high color bright priority should be selected and grayscale gain kept to minimum. So you'll want to have the color Doppler box sized over the area and adjacent tissue. And the focal zone should be placed just below the area of interest. Okay, that's the only thing I'm doing today. So really, we'll pick up here next week and have a good day.